Welcome to another episode from the Veterinary Medicine Digest. Today, we are embarking on a deep dive into a condition that is frequently suspected, often challenging to diagnose, and crucial to manage correctly in our canine and feline patients: gastroesophageal reflux. We'll be exploring the inflammation it causes, known as esophagitis, untangling the web of its causes, navigating the complexities of diagnosis, and discussing the most rational and evidence-based treatment strategies available today. From the wheezing French bulldog to the cat with a mysterious lack of appetite, the signs can be subtle and the underlying issues surprisingly complex. So let's get started. To begin, it is important to define our terms. Esophagitis is, simply put, an inflammation of the esophageal mucosa, the delicate lining of the tube that carries food from the throat to the stomach. In a vast majority of cases in dogs and cats, this isn't a primary disease that just happens on its own. Instead, it is most often a consequence of injury from gastrointestinal reflux, which is the backward flow of stomach and sometimes intestinal contents into the esophagus. The caustic mix of gastric acid and bile acids can cause significant chemical injury to the esophageal lining. In human medicine, this condition is well known as gastroesophageal reflux disease, and it is most frequently thought to result from an incompetent lower esophageal sphincter, the muscular valve at the bottom of the esophagus. When this sphincter doesn't close properly, reflux can occur. However, diagnosing this as a primary functional problem in our veterinary patients is much trickier. We cannot rely on a detailed questionnaire about symptoms like heartburn, as is done in people. Our patients exhibit clinical signs, which are subjective experiences that we, as veterinarians and owners, must interpret. To make matters more complicated, the most common form of this disease in humans is the non-erosive type, where there are no visible lesions during an endoscopic exam, despite the presence of reflux-associated symptoms. It stands to reason that we are likely missing many of these subtle cases in our own patients. The one major exception to reflux being the primary cause of esophagitis is an emerging condition known as eosinophilic esophagitis. This is considered a primary inflammatory disease of the esophagus, likely driven by an allergic or hypersensitivity reaction, leading to a massive accumulation of eosinophils, a type of white blood cell, within the esophageal tissue. This infiltration then causes tissue damage, swelling, inflammation, and even fibrosis. While only a few case reports exist so far, it is a condition we need to keep on our radar, as it may be currently underdiagnosed in both dogs and cats. Now, let's explore the wide array of conditions that can lead to this damaging reflux. By far, the most common scenario for esophagitis in both dogs and cats is perianesthetic reflux. This is the reflux that occurs while a patient is under general anesthesia. The relaxation of the lower esophageal sphincter is a known effect of many pre-anesthetic and inhalant anesthetic agents. Studies have shown that the incidence of gastroesophageal reflux in dogs under general anesthesia can vary widely, with reports ranging from as low as 5% to as high as nearly 88%. Clinical signs, such as a decreased appetite or painful swallowing, typically begin a few days after the anesthetic event, and the diagnosis is often made based on this history. Several factors can increase this risk. For instance, intra-abdominal procedures carry a higher risk for reflux. The duration of preoperative fasting and the specific pre-anesthetic drugs used also play a significant role. For example, the administration of morphine before anesthesia has been shown to increase the frequency of reflux. In very severe, though thankfully rare cases, perianesthetic acid reflux has even led to lethal esophageal rupture. This link between anesthesia and esophagitis is so well established that it's considered the most common cause of high-grade esophagitis and subsequent esophageal stricture formation in dogs, accounting for nearly half to two-thirds of cases. Another significant cause, particularly in our feline patients, is medication-induced esophagitis. Cats seem especially susceptible to pill-induced esophagitis when they are given oral medications without a chaser of water or food. Certain antibiotics, like clindamycin and doxycycline, have been frequently implicated. Doxycycline hyclate, in particular, is known to form a highly acidic solution when it dissolves, with a pH between 2 and 3, which is incredibly damaging to the esophageal lining. This is why it is now strongly recommended to administer a small water bolus after giving any oral medication to a cat to ensure the pill or capsule is cleared from the esophagus and safely deposited in the stomach. Structural and functional issues are also major contributors. Lodged foreign bodies, for instance, can physically obstruct the esophagus and permit increased exposure to reflux. Similarly, frequent vomiting from any cause, malpositioned esophageal feeding tubes, and tumors at the far end of the esophagus, often benign muscle tumors called leiomyomas, can all disrupt normal function and lead to reflux esophagitis. Then we have conditions that directly increase stomach acid or delay its emptying. Primary gastric hyperacidity conditions like a gastrin-producing tumor, known as Zollinger-Ellison syndrome, can lead to esophagitis when excessively acidic contents reflux. Likewise, delayed gastric emptying caused by conditions like acute pancreatitis or pyloric outflow obstructions can result in the same outcome. One of the most important and increasingly recognized predisposing factors is Brachycephalic obstructive airway syndrome, or BOAS. This condition, seen in flat-faced breeds like French bulldogs, English bulldogs, and pugs, is a conformation-related respiratory disorder. The increased effort these dogs must make to breathe in against their obstructed upper airways creates a significant negative pressure within their chest cavity. This negative pressure can actually pull the stomach up through the diaphragm's esophageal opening, leading to a hiatal hernia. A hiatal hernia alters the functional anatomy of the gastroesophageal pressure barrier, impairing the natural defenses against reflux and also hindering the esophagus's ability to clear any acid that does make its way up. This connection is so strong that the prevalence of gastrointestinal tract lesions in brachycephalic dogs presenting for respiratory signs is reported to be as high as 97%. Their clinical signs are often a mixture of regurgitation and the retching up of frothy material, especially during periods of increased activity or excitement. This entire complex interplay between their respiratory struggles and their digestive system is a critical aspect of managing these popular breeds. Other, less common causes of upper airway obstruction can also lead to reflux esophagitis through the same mechanism of increased negative intrathoracic pressure. Additionally, dogs with idiopathic laryngeal paralysis have been shown to have more acidic reflux events, with reflux sometimes reaching the very top of the esophagus. It is also important to consider that esophagitis itself can create a vicious cycle. Inflammation in the esophagus can cause esophageal hypomotility or poor movement and can weaken the lower esophageal sphincter by impairing the nerve pathways that control it. In cats, experimentally induced esophagitis was shown to decrease lower esophageal sphincter pressures, but these changes were reversible once the esophagus healed, highlighting how inflammation can perpetuate the problem. Finally, it is crucial to remember that what we might suspect is primary reflux esophagitis could actually be a manifestation of a different underlying issue, specifically inflammatory small bowel disease or chronic inflammatory enteropathy. These conditions can present with very similar clinical signs. In fact, many patients whose signs are initially blamed on reflux esophagitis are ultimately diagnosed with chronic enteropathies and can be successfully managed in the long term with dietary changes, probiotics, or medications like budesonide. This overlap is a major diagnostic challenge and a key reason why a thorough workup is so essential. With such a diverse list of potential causes, how do these animals present to us? The clinical signs of esophagitis can be incredibly varied and sometimes completely absent, especially in mild cases. The signs can be immediate, caused by the inflammation itself, or delayed, resulting from the formation of a stricture, which is a narrowing of the esophagus due to scar tissue. Animals with more severe esophagitis might show a decreased appetite or outright anorexia. They may exhibit signs of painful swallowing, known as odynophagia, or difficulty swallowing, which is dysphagia. You might observe tylism, which is excessive drooling, or an increase in empty swallowing motions. A classic, though not always present, sign is the extension of the head and neck while swallowing, as the animal tries to straighten the path for the food bolus to ease its passage. Retching, vomiting, and regurgitation are also common. It is important to distinguish between vomiting, an active process involving abdominal contraction, and regurgitation, which is a passive process often associated with esophageal disease. In many cases, the signs are much more subtle and can be easily misinterpreted. An owner might report sudden, unexplained discomfort, belching, excessive grass eating, or obsessive surface licking. Brachycephalic breeds, like French bulldogs, often present with a combination of regurgitation and retching up frothy material, particularly when they get active or excited. The veterinary literature describes an even broader range of subtle signs. These can include gagging, repeated swallowing motions, lips smacking, and particularly discomfort at night or a sudden onset of nervousness and restlessness. An animal might seem very interested in food, but then refuse to eat it, which would be a key indicator of pain associated with swallowing. It is logical to assume that the severity of these clinical signs would correlate with the extent of the lesions in the esophagus, but this is not always the case. Some animals with significant endoscopic lesions may show minimal signs, while others with seemingly mild inflammation can be profoundly uncomfortable. The onset of signs related to anesthesia-associated reflux esophagitis can also be variable, appearing anywhere from 1 to 3 days to as long as 2 weeks after the anesthetic event. Beyond the esophagus, we must also look for extraesophageal signs. Inflammation can extend upwards, causing injury to the larynx and upper airway, which might manifest as hoarseness, a harsh breathing sound called stridor, or a cough. A physical exam might reveal bad breath, or halitosis, and signs of laryngeal inflammation like redness and swelling of the vocal folds, though it is important to note that the majority of patients with esophagitis will have a completely normal physical examination. If the inflammation is severe and chronic enough to cause a stricture, the signs will depend on how narrow the esophagus has become. The more narrow the stricture, the more pronounced the regurgitation will be. Mild strictures might not cause any signs at all until the patient tries to swallow a large or firm piece of food. Sometimes, the signs progress gradually as the scar tissue of the stricture continues to contract, causing the lumen to narrow further over time. Finally, we must always evaluate the respiratory system. It is believed that, similar to humans, esophagitis can lead to inflammatory airway disease. Chronic, intermittent microaspiration of gastric acid into the lungs can potentially cause aspiration pneumonia, chronic bronchitis, and possibly even interstitial pulmonary fibrosis. There is a particularly interesting observation regarding West Highland White Terriers. This breed is known to be predisposed to both lodged esophageal foreign bodies and idiopathic pulmonary fibrosis. This has led to the theory that chronic microaspiration of gastric acid, perhaps secondary to an underlying esophageal motility problem, might be a contributing factor to the lung disease in this breed. Given this wide and often nonspecific array of clinical signs, the diagnostic journey can be a long one. The initial steps, including a thorough history and physical exam, may raise our suspicion, but routine laboratory testing is almost always normal. So, we must turn to more advanced diagnostics to confirm our suspicions. Let's start with diagnostic imaging. Standard radiographs, or X-rays, are of limited use for detecting esophagitis itself. The findings might be very subtle, such as mild esophageal dilation or some fluid accumulation in the distal esophagus. However, radiographs are invaluable for ruling out or identifying many of the underlying causes we have discussed. They can reveal foreign bodies, hiatal hernias, masses, or vascular ring anomalies. They can also show lung patterns that suggest aspiration pneumonia. To get a better look at the esophagus itself, we often use contrast esophagograms, where the animal swallows a barium solution. Unfortunately, the sensitivity of a barium esophagram to detect esophagitis is low. In cases of moderate to severe inflammation, we might see mucosal irregularities or a prolonged retention of the contrast medium, but milder forms of esophagitis will almost certainly be missed. A more dynamic and informative version of this test is a video fluoroscopic swallow study, which is essentially a real-time X-ray movie of the swallowing process. This allows us to assess esophageal motility throughout the entire swallow and is less likely to miss a brief moment of abnormality that could be overlooked with static images. It is crucial to perform this study with both liquid contrast and a food barium mixture, because sometimes liquids can pass a partial stricture without issue, while a solid food bolus will be retained. While fluoroscopy is excellent for assessing the causes and consequences of esophagitis, such as reflux episodes, hiatal hernias, dysmotility, or strictures, it is not a useful tool for diagnosing the inflammation itself. More recently, advanced imaging like computed tomography and magnetic resonance imaging have been used. A recent study specifically looked at the prevalence of gastroesophageal reflux in dogs undergoing magnetic resonance imaging for spinal issues. The study found that fluid in the esophagus, which is easily seen on T2 weighted images as a bright signal, was present in just over 50% of the dogs scanned. This is a remarkably high prevalence and falls within the wide range previously reported in studies using other methods. The researchers even developed a subjective 5-grade system to classify the volume of fluid from a very small amount just coating the lining to a very large volume, causing marked dilation. Interestingly, they found that a larger volume of reflux was significantly associated with a higher chance of clinically observed regurgitation. This suggests that detecting and quantifying reflux on these scans could be a helpful tool for anesthetists to identify at-risk patients. The study also highlighted that brachycephalic dogs did not have a statistically significant higher rate of reflux compared to non-brachycephalic dogs in their population, though the authors noted their study might have been underpowered to detect a true difference. This contrasts with another study using computed tomography, which found a much lower incidence of reflux, around 19%, in non-brachycephalic dogs. The higher sensitivity of magnetic resonance imaging for detecting small amounts of fluid might explain this discrepancy. While imaging gives us valuable clues, the most sensitive method to directly diagnose esophagitis is endoscopic examination, or esophagoscopy. This involves passing a flexible camera into the esophagus to visualize the mucosal lining directly. Early signs of esophagitis that we might see include erythema, which is redness, and edema, or swelling, usually just above the lower esophageal sphincter. Other signs include increased vascularity, wherein large capillaries become visible near the surface in response to acid injury. In dogs with prolonged acid exposure, we might see tiny round dots, which are the excretory ducts of proliferating submucosal glands. The mucosal surface can also appear rough and puckered, a change described as increased granularity. In severe cases, we can see areas covered with exudative pseudomembranes or even frank ulceration. However, even endoscopy has its limitations. A grossly normal-appearing esophagus on endoscopy does not rule out esophagitis. This is a critical point. Studies in both dogs and cats have reported cases with histopathologic evidence of esophagitis despite a normal-looking mucosa on endoscopy. This is consistent with what is seen in human medicine, where the majority of patients with gastroesophageal reflux disease have what is termed non-erosive esophageal reflux disease, meaning no visible mucosal damage. This is why esophageal histology, the microscopic examination of tissue samples, is so important. It is strongly argued that an esophagoscopy performed without taking biopsies is insufficient to rule out esophagitis. However, obtaining adequate biopsies can be difficult. The esophagus is lined with a tough, stratified squamous epithelium, and standard biopsy forceps may only yield small, superficial bits of tissue. Despite these challenges, microscopic abnormalities like inflammation, fibrosis, or changes in the structure of the epithelial layers can be identified even in small samples. In human medicine, hyperplastic thickening of the basal cell layer and abnormal elongation of stromal papillae were once considered hallmark signs of gastroesophageal reflux disease. Similar hyperregeneratory changes have recently been reported in dogs with clinical signs suggestive of reflux esophagitis, and in many of these dogs, their signs improved with proton pump inhibitor therapy. While this is a promising area of research, the specificity and sensitivity of these histologic lesions for diagnosing reflux esophagitis in our patients still need to be fully evaluated against a quantifiable gold standard. All of the diagnostic methods we have discussed so far, imaging, endoscopy, and histology, can help us diagnose esophagitis, but they fail to do one crucial thing. They cannot directly detect and quantify reflux events. This is where a technique called esophageal pH metry comes in. In human medicine, catheter-free esophageal pH monitoring has become the gold standard for diagnosing gastroesophageal reflux disease. This technology allows us to measure the acidity inside the esophagus over an extended period, typically for several days. A widely used system is the Bravo system, which involves a small capsule containing a pH electrode that is endoscopically placed and attached to the esophageal mucosa about 3 to 5 centimeters above the lower esophageal sphincter. This wireless system has been found to be a useful and safe tool for extended ambulatory monitoring in dogs, tolerated well by patients ranging from 6 to 55 kilograms in body weight. Once the capsule is in place, it transmits pH data to an external receiver worn by the dog. Owners are instructed to keep a detailed logbook and press specific symptom buttons on the receiver whenever they observe clinical signs they believe are related to reflux. This allows for a temporal association to be made between a clinical sign and a reflux event, which is defined as a drop in esophageal pH to below 4. In people, a strong correlation, where at least 50% of symptom events are related to a reflux episode, is considered a positive finding. The results from a study using this system in dogs were quite surprising. In healthy dogs, the total fraction of time that the esophageal pH was less than 4 was very low, typically ranging between 0 and 3%, which is actually lower than what is considered normal in humans. The really unexpected finding was in the group of dogs with clinical signs commonly attributed to reflux esophagitis. In 17 out of 22 of these suspected cases, clinically relevant reflux episodes could not be demonstrated. Furthermore, a clear temporal relationship between the clinical signs observed by owners and actual reflux events could not be established. While the study was limited by a small number of healthy control dogs, it led to a very important conclusion. The differential diagnosis of a diet-responsive enteropathy should be thoroughly ruled out before pursuing aggressive treatment for esophagitis, because the clinical signs of these two diseases can be strikingly similar. This underscores the complexity of these cases and reminds us that what looks like a primary esophageal problem might actually be originating further down the gastrointestinal tract. Now that we have navigated the intricate path of diagnosis, let's turn our attention to therapy. The ideal treatment for esophagitis is, of course, directed at the underlying cause. It is crucial to eliminate any predisposing factors. If a brachycephalic dog has a chronic obstructive upper respiratory problem, corrective surgery to alleviate that obstruction may also resolve the inflammatory esophageal lesions. The same principle applies to surgically correcting a hiatal hernia. Since anesthesia is the most common cause of reflux esophagitis, preventing reflux in patients undergoing anesthesia is a major goal, especially for those with a history of post-anesthetic issues. Various strategies have been investigated. Pre-treatment with the prokinetic drug metoclopramide has yielded conflicting results. Giving the H2 receptor antagonist ranitidine before surgery also did not seem to reduce the incidence of reflux. A more promising approach appears to be a combination of a proton pump inhibitor, like esomeprazole, with a prokinetic agent like cisapride. This combination was shown to decrease the number of reflux episodes in anesthetized dogs. Giving the proton pump inhibitor alone was felt to be less effective because while it decreased the acidity of the refluxate, it did not reduce the overall number of reflux events. In cats, giving 2 oral doses of omeprazole before anesthesia, one 18 to 24 hours before and another 4 hours before, was shown to significantly increase esophageal pH, and no reflux episodes at all were recorded in the treated cats compared to the placebo group. When treating suspected reflux esophagitis, the therapeutic principles are similar. Increase the lower esophageal sphincter pressure to prevent reflux and suppress gastric acid to prevent further injury and allow the esophagus to heal. We know that in cats, esophagitis itself can decrease lower esophageal sphincter pressure and impair esophageal clearance, but these changes are reversible with healing. In dogs, the prokinetic drug cisapride has been shown to significantly increase lower esophageal sphincter pressure, whereas contrary to common belief, orally administered metoclopramide did not have a significant effect. A cornerstone of medical management for suspected esophagitis is a combination of gastric acid suppression and the mucosal protectant sucralfate. When it comes to acid suppression, proton pump inhibitors, such as omeprazole and esomeprazole, provide superior gastric acid suppression compared to H2 receptor antagonists like ranitidine or famotidine. Therefore, proton pump inhibitors should be considered more effective for treating acid-related disorders in both dogs and cats. To maximize their effect, a twice-daily dosing regimen is generally advised. There is no conclusive evidence in our veterinary patients to suggest that one proton pump inhibitor is clinically more effective than another. However, it is important to remember that these drugs can have interactions. By increasing the gastric pH, they can decrease the oral absorption of other drugs that require an acidic environment, such as certain azole antifungal medications or mycophenolate. Also, after prolonged use of 4 weeks or more, proton pump inhibitors should be gradually tapered rather than stopped abruptly to avoid a phenomenon known as rebound gastric acid hypersecretion. What about H2 receptor antagonists? While commonly used, studies have shown they are inferior to proton pump inhibitors for increasing intragastric pH in both dogs and cats. Furthermore, their effectiveness diminishes over time due to pharmacological tolerance, a phenomenon known as tachyphylaxis, which can occur within just a few days of continuous administration. For these reasons, monotherapy with an H2 receptor antagonist given twice daily is considered inferior to twice-daily proton pump inhibitor treatment for managing gastroduodenal ulceration or reflux esophagitis. Then there is sucralfate, a mucosal protectant that is intended to bind to inflamed tissue and create a protective barrier. It is thought to block the diffusion of gastric acid and pepsin across the mucosa. While the rationale is based on its adherence to denuded surfaces in an acidic environment, and the canine esophagus is typically weakly alkaline, clinical experience suggests it does seem to soothe the patient's discomfort when dosed multiple times a day. In people with severe corrosive esophagitis, intensive high-dose sucralfate therapy has been shown to enhance mucosal healing and prevent stricture formation. While there is weak evidence to support its use for esophageal injury in experimental animals and humans, and no controlled studies have been done on its analgesic effects, it remains a common part of therapy. When administering sucralfate to dogs and perhaps cats, it is recommended to use it as a liquid suspension rather than an intact tablet, as the tablets may not fully disintegrate and could be less effective. Other medications may be considered in specific situations. Misoprostol, a synthetic prostaglandin E1 analog, has been shown to be effective for decreasing gastric lesions in dogs treated with high-dose aspirin. However, its effectiveness for gastrointestinal injury from other nonsteroidal anti-inflammatory drugs is unknown, and there is no evidence that it helps with corticosteroid-induced ulceration. For the rare cases of eosinophilic esophagitis, treatment has been successful with dietary antigen elimination using a hydrolyzed diet in a cat and with corticosteroids in a dog. Finally, we should not forget lifestyle changes. In people, management of reflux esophagitis often includes losing weight, avoiding bedtime snacks, and elevating the head of the bed at night. While there are no data on these strategies in our small animal patients, they intuitively make sense and could be considered as part of a holistic management plan. The most impactful lifestyle change, however, may be dietary. As we have discussed, in unclear cases that do not respond well to acid suppression, a chronic enteropathy should be suspected and strict dietary trials should be implemented, as many of these patients will ultimately respond to dietary changes alone. In summary, esophagitis in our dogs and cats is predominantly a secondary consequence of prolonged esophageal exposure to gastroduodenal reflux, which can stem from a multitude of underlying causes, from anesthesia to the very conformation of our brachycephalic breeds. While an incompetent lower esophageal sphincter, similar to the condition in humans, is often suspected, the clinical signs our patients show are varied and can be difficult to interpret, often overlapping with those of primary intestinal disease. A definitive diagnosis can be a challenging journey, confirmed through a combination of endoscopy, esophageal biopsies, advanced imaging, and ideally, wireless esophageal pH monitoring. Treatment should always be aimed at the root cause, but medical management with sufficiently dosed proton pump inhibitors remains a mainstay of therapy. However, in those puzzling cases that fail to respond as expected, we must always circle back and consider the possibility of a chronic enteropathy, where a simple and strict dietary trial may ultimately provide the answer. The world of gastroesophageal reflux in our pets is a perfect example of how a seemingly straightforward problem can have deep and complex roots, requiring careful investigation and a thoughtful, multifaceted approach to management. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging,